Hello, welcome. We're having another session of digital slide review and sign out. I'm Dr. Lewis Hassel, coming to you from the University of Oklahoma Health Sciences Center in Oklahoma City. Our case today is one derived from the slide files of the Digital Anatomic Pathology Academy, which is a joint venture of Path Presenter and the Digital Pathology Association. Membership in which I will mention is free to residents and trainees in pathology. So this is a dilemma that comes up not infrequently. Is there dysplasia in this sample? And if so, to what degree do we worry about it, and so forth, particularly in the realm of esophageal pathology. So our case today, a 58-year-old man who's had dyspepsia for some years and on endoscopy has an abnormal appearing mucosa in the distal esophagus. It actually has somewhat of a mass type lesion to it, and so the endoscopist performs a endoscopic mucosal resection, which you can see representative sections of here. We have excised the deeper portions here down into possibly the submucosa, and we can see that the surface is abnormal. The architecture is somewhat altered. Certainly we don't see a stratified squamous mucosa. And then we see some, perhaps some glandular structures here that could be neoplasia and so forth. But let's sort of focus first on maybe the more normal appearing area here. And we see that this area has columnar mucosa on the surface. And this is mucosa with a good number of goblet cells in this columnar epithelium. The nuclei are somewhat crowded and stratified. And yet, as they reach the surface here, we see that they tend to normalize a bit and be spread out. We also see that there's some Paneth cells in the deeper crypts here. Then we have these maybe pyloric type glands down here deeper. Those need to be inspected at times because sometimes those can masquerade or invasive carcinomas can masquerade as though they're benign pyloric glands, which we don't seem to have here. So we have here columnar mucosa with intestinal metaplasia, which in the United States at least qualifies as Barrett's esophagus, assuming we are here within the tubular esophagus. So then what to do with this? So here we see that the architecture has become somewhat villous. And as we look at these epithelial cells, we see that they begin to be crowded. There's certainly some stratification of the nuclei. They're still sort of pencil-shaped, as we might see with a tubular adenoma of the lower GI tract. But we see some tufting and maybe a little extension into some of the deeper glandular tissues, and some irregularity to the size and shape. Here's sort of a boot shape, a little solid area. And again, we've lost the cytoplasmic mucin. We can see some mitotic figures in here as well. Certainly increased numbers of mitoses. I haven't seen any abnormal mitoses at this point. And we don't see much in the way of inflammation or other confounding factors that would lead us to consider other possibilities. Now we'll go up here a little further and see that here the proliferation has become almost solid. So it's sort of becoming much more confluent and stratified. Here we have a little bit of ulceration and debris. And then here again, it's becoming more architecturally complex. There's some surface erosion here, a little ulceration. We can identify here that there are strands of muscularis mucosa in here. And these other glands here do not have the same cytologic or other characteristics that we would associate with invasive neoplasia, but rather tend to have a more foveolar type of appearance, or perhaps even, as I said, a pyloric type glandular configuration. And they're still configured here within strands of smooth muscle in an orderly fashion. Looking at the other fragment here, we can again see areas of intestinal metaplasia here. We can see areas here where a little bit more confluent and potentially some increased mitoses in the base, but again, the surface appears to have maturation. So I would classify that as non-dysplastic at that stage. Now here we again have the villus architecture, elongated villi here, complex tubulovillus appearance. And then here we have a gland, probably a submucosal gland, which has become inflamed. And then notice here we see that these glandular tissues do not transgress this muscularis mucosa boundary here. So we have here dysplasia, we have Barrett's esophagus, we have some submucosal glands, and as we look at the margin here we've got cautery here, and we have dysplasia here at the margin. So we've answered some of the key questions here. We don't see invasive neoplasia. We do see metaplasia and dysplasia in this patient with Barrett's esophagus. So Barrett's esophagus, of course, is a metaplastic change from squamous to columnar mucosa that involves the tubular esophagus and by definition clinically is greater than 1 centimeter from the gastroesophageal junction. Now, obviously, as a pathologist, histologically, you can't define the gastroesophageal junction. So this is a point in time when you need to work closely with your endoscopist to determine whether or not this is truly Barrett's esophagus. However, what you can do is describe carefully what you see. Goblet cells, in other words, intestinal metaplasia, are requisite for the diagnosis of Barrett's esophagus, at least according to the American College of Gastroenterology. The British Society, however, does not ascribe that to that more narrow diagnosis and will accept any any metaplastic columnar epithelium as potentially Barrett's esophagus as long as it is present in that distribution greater than 1 centimeter from the GE junction. No matter how you define it, this is a disease that's strongly associated with gastroesophageal reflux and in certain circumstances has other risk factors for this disease would include Caucasian, ethnicity, older age, smoking, and so forth. And the most important thing is that, of course, that this predisposes to the development of dysplasia and subsequent carcinoma, and therefore is a mandate for regular screening and various treatment interventions to reduce that risk and to reduce that incidence. So let's look at a more typical gastroesophageal biopsy. Here again, we can see that we have columnar epithelium. Now, this is what many esophageal biopsies will look like, and obviously we can't tell where the squamous mucosa is or was in this circumstance. All we can see is that there is columnar epithelium here, there are crypts, and as we go to a little higher magnification, we can see these goblet cells that are present in the mucosa. Now, in some circumstances, you have pseudogoblets, in other words, cells that look a little bit like goblet cells but are not truly containing intestinal type mucin. And in those circumstances, sometimes special stains using stains to highlight the more acidic mucins of the intestinal tract are useful. The PAS Alcian blue stain has been used in some laboratories very extensively for this purpose. Now, in this biopsy, is there dysplasia? Well, first off, we don't see any particular architectural abnormalities here, and we certainly see what looks to be a fairly normal appearing surface columnar epithelium without areas of hyperchromasia We don't see goblet cells along the surface, but there is a mature appearing surface epithelium. So this would not be dysplastic. Looking at another example, here again, we can see now that we have something at least close to the squamous columnar junction, squamous mucosa here, and columnar mucosa here. Now, is this just normal gastric cardia, or is this Barrett's esophagus? Well, you know, we can't tell histologically. We don't know where this came from anatomically, other than that it's at a squamo-columnar junction. What we can do, however, is describe what we see. We see columnar mucosa with areas of true goblet cell metaplasia. And typically these true goblets have just a very pale blue tinge to them, whereas pseudogoblets, sort of more like this over here, would tend to have a more pink or pale appearance. And so that can be helpful. So here we see intestinal metaplasia, and then going to our next criteria, do we have architectural abnormalities? Well, we have a little bit of crowding of these glands here in the crypts, but is there surface maturation? Yes, there does appear to be generally surface maturation. We don't see much pseudostratification. We don't see hyperchromasia. We don't see too much in the way of nuclear atypia, at least on the surface. Now, here in the deeper portions, we can see some degree of atypia, and we can see some sense of crowding. In most observers, this would not qualify as dysplasia, because it did not reach the surface. But it certainly puts you on notice that you should be looking for that possibility. In reality, this may represent the earliest stages of dysplasia, but not having reached the surface, it would certainly not be at the stage where more frequent follow-up would be warranted in these patients. Here's another example. Again, we see squamous mucosa here on this end with the squamo-columnar junction. Here again, squamous mucosa, squamo-columnar junction. And again, we can see that in this case, there are a few isolated goblet cells. So this is an area of intestinal metaplasia, and at least according to the American College, would satisfy the diagnosis for Barrett's esophagus, assuming that it is involving a segment of the true esophagus. Now, there are other terms like long segment, short segment, and so forth to deal with circumstances where the volume of disease may be limited. We won't go into that here. However, we do see a little bit of glandular crowding here, but we don't see other features of cytologic atypia in this setting. And we certainly don't see any evidence that the surface is altered or dysplastic. It doesn't bear any resemblance to a tubular adenoma that's nicely organized and not stratified to any significant degree. So another case of squamous mucosa, columnar mucosa with intestinal metaplasia. Now, the diagnosis of intestinal metaplasia of the gastric cardia has in some circles been regarded as a variant of Barrett's esophagus, but probably doesn't have quite the same degree of risk of subsequent carcinoma. And hence the importance of simply describing as you sign out what you see, rather than ascribing a name like Barrett's esophagus or intestinal metaplasia of the gastric cardia, unless you have other firm evidence or clinical endoscopic correlation as to the exact location of the disease that you're evaluating. So the question of dysplasia in Barrett's esophagus, I think, boils down to probably 3 or 4 principal criteria. The first is, do we have surface involvement? And we've illustrated that with these several changes. Is the surface epithelium altered? Is it dysplastic? And then secondly, we're looking for the kind of architectural changes. Now, in our first slide, we saw villus architecture. That's a marker of more advanced dysplasia. Do we see glandular crowding? Do we see irregular glandular shapes? Do we see cribriforming? Again, these are markers of higher grade dysplasia. And then lastly, do we see sort of deeply dropping glands? Do we see things sort of tending downwards? And sometimes as this happens, the glands tend to lose their cytoplasm and pretend to be benign, but in actuality are carcinomas that are beginning to invade. And then the last criteria is the cytologic features. Is there loss of mucin? That certainly can help with both low and high grade dysplasia. Is there increase in the NC ratio? The greater that increase, the more likely it is to be high grade. And then do we see nuclear stratification, or do we begin to see nuclear pleomorphism and rounding up and variability in the size and shape of the nuclei? Again, a feature that tends to favor higher grade dysplasia. And then perhaps the least useful criterion is increased mitotic figures. But if you begin to see abnormal mitoses, tripolar, quadrupolar mitoses, then that can be a marker, certainly of dysplasia, and more likely inclining towards high-grade dysplasia. Finally, are there other confounding factors? Is there inflammation? Is there some sort of secondary ulceration, perhaps due to peptic reflux or something of that sort, that could compromise your ability to interpret these cytologic and architectural features? And if so, then you may be best to place it in the indefinite for dysplasia category. So here's another example. Let's test out those criteria in this circumstance. So we have 3 fragments. We see squamous fragment, and then we see this fragment, which has clear-cut intestinal metaplasia. So do we have surface involvement? Well, it looks as though here we're a little bit hyperchromatic and a little bit stratified on the surface. We may have some nuclear pleomorphism there. So we are beginning to get towards at least low-grade dysplasia there, because this is certainly different than this other more normal appearing intestinal metaplastic epithelium there. Now we do have a confounding factor here. We have some inflammatory cells, and so we might be a little cautious, but we don't see too much of that change here. So this may be suitable for the diagnosis of low-grade dysplasia. Then as we look a little further, we see that the architecture of some of these deeper glands is indeed altered, and we have the beginnings of some cribriform change here. And we can see that there are, some multiple lumina and mitotic figures here in this tissue down here. So that being the case, we might be at this situation to say low-grade dysplasia, at least low-grade dysplasia, with a little question in our mind as to high grade in that fragment. Let's look at the other fragments, however, and see what we have here. So here we have squamous mucosa. We have some columnar epithelium here and here. We don't even see definite intestinal metaplasia here. And the amount of inflammation is mixed. There's some on the surface here, certainly some within the epithelium. So there is some degree of reflux or irritation to this squamous mucosa, but nothing there that we would call dysplasia. So looking at this third piece, again, we have a little squamous, and then we have this more complex architecture here. We don't see intestinal metaplasia, but what we do see is we do see these cells becoming more complex, higher NC ratio. The nuclei are considerably more portion of the cell size than at other locations. So that loss of cellular volume is a marker for dysplasia and higher grade dysplasia. We see some crowding and a little bit more pleomorphism of the nuclei here. And although this is a bit of a thick section, we can even see here's a little bit of a cribriform area here. And so in this situation, with this loss of cytoplasm, higher NC ratio, pleomorphism, occasional architectural changes and more complex changes, in conjunction with the low-grade dysplasia that we saw elsewhere, this lesion might best be classified as at least high-grade dysplasia. Now, can we eliminate the possibility of invasive neoplasia here? Well, no, we can't, because we don't really see the full depth of this lesion in these biopsy samples. So this sort of illustrates, I think, the key criteria and also the key boundaries that we need to attend to in pathology. So the first is the boundary between Barrett's esophagus and low-grade dysplasia. This is an important boundary to define and to be consistent with, and to seek for consensus with one's colleagues, because this changes the management. It changes the screening frequency and the intensity of biopsy follow-up. The boundary between low-grade and high-grade dysplasia is also a key boundary because that changes management and leads one more likely to get an endoscopic mucosal resection, increased frequency of screening, increased numbers of biopsies, and so forth. In contrast, the boundary between high-grade dysplasia and intramucosal carcinoma results in very minimal change in management. Both of these need to be excised if they can be, ablated if they are amenable to that, or otherwise dealt with in a more aggressive fashion. Not particularly different. The boundary between intramucosal carcinoma and invasive carcinoma depends a little bit in terms of how different the management will be there. The only real difference comes when we have established either clinically or microscopically that the lesion invades beyond the muscularis mucosa and hence is at least a T1B, because that then becomes a more surgical disease rather than an endoscopically superficially managed disease. So thank you for joining me on this case today. Our final sign out is Barrett's esophagus with high-grade dysplasia. We did not see invasive carcinoma in that first endoscopic mucosal resection. Our margin was focally involved by high-grade dysplasia and would therefore mandate further follow-up and potential excision at an earlier date. Well, we hope you've enjoyed this, and if you like it, you'll comment below. Please subscribe so you won't miss future updates and future releases. And we always welcome your comments, either directly or in the comments below. So until next time, thanks for joining us.